All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, our rock star, who has been with us many times before, is joining us today once more. And I think that he brings in some insights that are really interesting. And maybe these are the things that you are experiencing as well. In today's talk, we're going to talk about what is the current state of the medical management and the errors and the mistakes and overwhelming of the community at this time, medical community. Number two, what is going on in terms of the newer issues that are appearing after COVID. And then number three, what are the management techniques that have been fruitful or useful, as Dr. Phillips is actually a very prolific practitioner as well. And his own story of chronic inflammation is something to hear and read as well. So, Dr. Phillips, welcome.
Thank you. Thank you so much.
So tell us a little bit about yourself, and I'm going to show your book and your Substack as well for the benefit of our audience. So
thank you. Yeah, we know each other for some time now. I've been in practice since 1996, and I've been researching zoonotic infections, which are infections that are spread from animals to people, things like Lyme disease and babesiosis and ehrlichiosis, and others like Bartonellosis and Coxiella, and many that people haven't heard of. And the book Chronic is about the chronic potential causes of chronic inflammatory and degenerative illness. And that came out a few years ago and has really helped a lot of people, which is why we wrote it.
So I want to actually, my apologies for the interjection. I have always been passionate about this book. You, my audience here, Cool Beans, you may not have seen me trying to push something to you other than this one book. Not even my own lectures I've tried to push. The reason for this is that majority of the population in the US, for example, have some chronic illness. 64% of the US population has some chronic illness. 50% or more of the worldwide deaths are because of some disease that is attributable to chronic illness. So chronic illness is going to catch us. And as we start aging, it becomes more and more prevalent in us. So understanding the chronic inflammations, understanding the causes of it, understanding how the doctors manage them, understanding how you can handle them is, I think, the most important thing that we can do to ourselves and we can do for our children. So here is that book once again. I am a big fan of this book. I think I've read it twice. And I even read the online chapter that came about COVID. So here is the chronic book. The link is in the description of this video. In addition to that, here is the Substack from Dr. Stephen Phillips. Dr. Phillips, would you like to tell us a little bit about your Substack as well?
Sure. I wrote the Substack because I became frustrated with what was going on when the media portrayal of ivermectin, which is a drug that I'd been familiar with for about, 10 years before COVID. And I'd used it extensively because it has really great immune modulating properties. Obviously, it's known as a life-saving antiparasitic in many parts of the world. So I was very, very familiar with this drug, its amazing safety profile. And I saw what was happening, and I thought it was a blatant smear campaign. So I wrote an article from a neutral perspective. It was called Ivermectin on Neutral Ground. And the article went viral. And that's when I realized that people had a need for some unbiased information that didn't have a narrative attached to it. And I started writing Zero Spin. It's been a nice outlet. I really enjoy it. And I think it's a nice service to the people. So.
Excellent. And again, nowadays, the FDA and Dr. Paul Marik and the team, their lawsuit with FDA, where their FDA is now saying, well, we never stopped anyone from prescribing ivermectin. On the ivermectin's topic, I want to ask you this. Ivermectin used to be used by doctors, like you said, even 10 years before, by doctors for inflammation, for skin conditions, and for modulating in case of chronic inflammation or rheumatology. Has that changed your patient's approach to ivermectin? If you prescribe some ivermectin today, do they say that, hey, you're giving me horse paste, or have FDA done a number on it?
The patients don't say that. I mean, we have frank discussions about that and my views of FDA's unfair characterization of ivermectin. But I do have to put a note to the pharmacy that it's not for COVID, and saying I use it for its immunomodulating properties, which is, so you have to kind of provide documentation to the pharmacies now, which is such a dystopian kind of a thing. You shouldn't have to. Doctors should not be beholden to pharmacists, I don't think. Not that it's just a weird reversal of the authority structure. I mean, the pharmacists are really getting in the way of the doctor-patient relationship, and I find myself having to explain things to pharmacists, which is not something we've ever had to do before. So it's weird, but we want my patients to be able to get a drug that can help them. So I jump through these hoops and make these explanations, and it takes me a few more minutes, and that's what it is. And but it's been a very, very helpful drug for my patients for many years. So I can talk about ivermectin all day, but I know that's not the topic of today's talk. Yeah.
Cool. And I want to make sure that I don't remiss mentioning that the book Chronic, your co-author, Dana Parrish. So author, Dr. Stephen Phillips and Dana Parrish.
Yes.
So her name, due credit, should go there as well.
Of course.
So with this, Dr. Phillips, tell me this, and I am genuinely curious about it. And that is, almost at the tail end of the pandemic, has your practice changed? Because you are a doctor who handles chronic inflammations, and COVID itself should have caused, in many people, chronic inflammatory states and changed their profile of their diseases that they may have. Then vaccines themselves would have something to do with all of this. How is your practice look like today?
So, the hardest sell, but the least controversial aspect of these chronic infections is that most of them don't result in overtly symptomatic illness. So studies from around the world, accepted by all the major infectious disease societies, they all show that there are very high rates of these infections in healthy people. What happens when these healthy people have their immune system dysregulated by a virus like COVID or some immunologic, let's say, intervention, whether it's a vaccine, a gamma globulin, or something else. And when people get kind of pushed off the immunologic edge, infections can activate or reactivate. And we're seeing activation for the first time. And I came on here and I talked about what we're seeing, I think it was in April, where we started accepting long COVID patients and patients who've had developed chronic illness after the COVID vaccines. And they had evidence of activated vector-borne infections. And not only are we getting them better, we're getting them better in half the time of my average patient, because they had strains of these infections that were never destined to be symptomatic. These are people who are healthy before they got their immune system kind of tipped over. So unlike my average patient, who was a bit harder to treat, these patients, ironically, despite having been sick for, over a year in many cases, have gotten better actually quicker. And then we've had a subset who had some clotting things as well as part of their illness long-term, and that's played a role. But what I've seen the most, unfortunately, is because, there's this very much increased demand for medical care as a whole. Chronic illness has been skyrocketing, like you said. It's 60-something% of the population has one. And there's been this massive increase in all-cause mortality, like 40% since pre-pandemic levels. And it's not just the mortality that's increasing, the morbidity is increasing. Doctors' offices are packed. They're absolutely swamped. And people, when they try to get in for routine medical care, they're waiting 6-7 months just to get an appointment. And I think that they're overloaded because I'm seeing errors that are beyond. And so 2 of the cases that I saw recently, I just figured we could talk about them because they're things that people should know about. Because I feel like if people don't have this information, these are really, really easy to miss. And for example, case number 1, I have a nice young woman who had a really difficult case of Bartonellosis before I saw her. She was in a wheelchair before me. She was out of the wheelchair by another doctor, came to see me, was still really completely disabled, however, and then we got her well. And it took about 2 years. And I haven't seen her in, I don't know, like maybe 4 years or something, and she's been really fine. And she's married and she got pregnant and she gave birth to a baby, and the baby is healthy. And at the time of the birth, she left behind with the epidural a grapefruit-sized pool of spinal fluid on the sheet from where she was laying down. And that's not normal to have such a large stain of spinal fluid. And shortly after that, she started getting positional headaches, and the headaches would get worse when she would stand up, and they would be relieved with rest, lying down. And then it got worse and worse to the point where she was spending more and more time in bed, and she couldn't care for her child. And she went back to this neurologist for 18 months. And the neurologist is a migraine expert and diagnosed her with migraine, despite her telling her this happened after this epidural. There was this huge spinal fluid leak at the time. It's like a medical board question. To me, this is egregious because she repeatedly said what the circumstances were, how it's positional headache, and the classic spinal fluid leak headache is relieved by lying down, and it's exacerbated by standing up. And it got to the point that she was in bed nearly 24 hours a day. And finally, somebody said to her, "We don't know what's going on. You know, you're so sick. It must be recurrent Bartonella. Go back to Stephen Phillips." And when she came back to me, I was listening to the story. I couldn't believe it. I was like seriously in disbelief. In 10 seconds, I was like, "You have a spinal fluid leak. You know, this has been going on for 18 months. I couldn't believe it." She was on, I don't know how many trials of different migraine medicines, maybe like 7 or 8. And they have this expression in medicine, when you have a hammer, everything's a nail. And so here's a migraine specialist who's diagnosing migraine, and somebody who clearly did not have migraine. And I told her, I sent her another neurologist. She got it's called a blood patch, when they inject a little bit of blood into the spinal canal, and the blood, you know, the platelets go and they just plug up the holes, and it stops the leak. And within 2 days, she's up and around, and she gets her life back. And I think it went on for 18 months. I still couldn't believe it. And then it was like 2 or 3 weeks later to the day, I had a patient, who was an old patient. I treated him as a teenager, and he had a really, really difficult case to treat, and he'd gotten a lot better. And he started getting headaches, which were also diagnosed as migraine. And his headaches were not positional at first. And then all of a sudden they became positional, and he had a similar kind of onset where he was spending more and more time in bed, and he couldn't stay vertical. He had to have a mattress in the living room because he was that bad, because he didn't want to spend all his time in bed. And he went to several neurologists with the story. None of them diagnosed him with spinal fluid leak. And one of them, he Googled it. He said, "You know, this positional headache, it says on the internet this is most likely thing is a spinal fluid leak." He went to the doctor and said, "Could this be a spinal fluid leak?" The doctor's like, "No." So I'm like, what is going on? What's going on? Are they rushed? Like, seriously, I don't know the mechanism by which this type of thing is missed. So I said, "Look, that just happened a few weeks ago with this other former patient." Or I said, "I really have to send you to a different," and he's from a different part of the country, so I sent him to a different neurologist, and he had a blood patch, and then he's up and around in also like 48, 72 hours.
So I actually have a very interesting observation here. I see doctors at this time in 3 kind of categories. One, as you said, doctors who are now receiving a lot more patients of chronic inflammations, either from the vaccine or from the COVID, or a combination, plus exacerbation of their existing conditions. And so some of them know what to do and some of them do not. And so there is a real struggle there for doctors, plus they just have a lot of patients. I also see that there are some doctors who are actually themselves suffering from long COVID type symptoms as well, which include brain fog and which include psychological profiles that become different. And they themselves are struggling to figure out how to keep up with the patient load and understanding and remembering the patient's situation. And then there's a third set of doctors who are the open-minded ones, who are researching, who are trying to figure out how do we solve for our patients. And so these are the 3 groups. And I want to give you an example. One of the vaccine injury patient, he's a very popular artist in this country, so I won't say who. He received a vaccine, and about a couple of weeks later, he developed some long COVID-like symptoms and became bedridden. He started his neurology appointments, and doctors started running various tests on him, and they found nothing. They said everything is fine. And of course, then they would start saying that, hey, maybe something psychologically is incorrect. And he found my name and phone number from someone. Someone told him that, hey, why don't you talk with Mubin? Now, for the audience here, I don't practice in the US. I'm not licensed doctor here. I'm a licensed doctor, but not here. So I don't practice. So when patients reach out to me here from the US, I just simply have to say that, hey, man, I can only help you maybe through these videos, or I can help you research something, but I cannot prescribe it. So I said, why don't you talk with your doctor about LDN? And Dr. Phillips, you will be amazed that one, thankfully, his doctor was open-minded. This patient went back, got some studies and literature, and discussed with his neurologist. A neurologist reluctantly said, okay, I'll give you LDN. Today, that patient, from being bedridden, is back mobile.
Mm-hmm.
And he reached out to me and he said, you had given me a tip for the LDN, which brought me back. Otherwise, I have done all mainstream tests for neurology, and I had the problem and nobody was able to figure it out. So do you feel that um, there is that kind of an era going on with the medical community?
I feel like they have to squeeze so many patients in such a little time slot for their expediency and make the numbers work. And patients have really devolved just to being numbers these days. It's a medical business, and it's lost so much of the human stuff. If somebody says, hey, let's look at this as a risk-benefit analysis, and you look at, if they bring literature about LDN, I mean, LDN has a ton of literature behind it, and if you actually look it up, it looks phenomenal. I wish it worked in as many patients as I would think it would work. Like, it works, but it works in a subset of my patients. And when it does work, it works very, very well. But it doesn't work for everybody. And then you have to have other tools. Like, doctors, open-minded is good. I feel like it's just some type of nuanced, thoughtful kind of way. I try to be neutral about everything. We use LDN in the practice. We use ivermectin as a immune modulator. We use antibiotics. We use non-antibiotic antimicrobials. We use herbals. We use whatever we can to get people better with the minimum of risk. And there are many ways to skin a cat. I have a good friend who doesn't come to see me as a patient, and she's been sick for a long time. And she sees a doctor who's known to use a lot of very dangerous medicines. And she's on these 6 medicines in really high doses. And I had a conversation with her yesterday, and I was like, you have your whole life ahead of you to try dangerous high dose medicines. Like, why not try something, less dangerous and go that route? But I do think that medicine has devolved, though. I put a poll out on Twitter not too long ago that to ask how their experience has been in a hospital setting, and virtually nobody had a good experience in the hospital setting. My mom had a traumatic brain injury about a year and a half ago, and she was in the hospital for a month. And the doctor called and said, "No, thank you." She's almost 91. And the doctor called and said that they have to put a feeding tube in her because their food intake is low. So we go there, and the food is wrapped up in the wrapping that they bring for the lunch on a table 6 feet away, and she's bed confined. And we're going to visit her, and the person who's coming to take the food away. I mean, it's not, you can't even make this up. And I was like, they can't even move the table over to a little old lady who's bed confined with a head trauma so she can maybe have a sandwich. I just was shocked that they're trying to put a feeding tube in here rather than, and then I called the nurse. I was like, she's been in bed for a while. Could you walk her up and down the hall? And she just laughed at me. She's like, are you kidding? No. Talked to physical therapy. Physical therapy wouldn't walk her up and down the hall. Their version of physical therapy was to get her out of bed to the door and back. And then she went to a rehab hospital, predictably, because they just let her decondition in bed for a month. And it's like, this system is so broken, and the hospitals are squeezing every penny out of this nursing staff, and they're running ragged. And I know a lot of nurses that work in hospitals, and it's not a great job. I mean, they're worked to the bone. And so Anyway, that's
Hmm.
so I do think medical care is going just downhill a little bit all over. I think hospitals is worse, and I think that the hospitals are unfortunately buying out private medical systems. And but getting back to the actual nuts and bolts medical stuff, so people can feel empowered and not like slip through the cracks when they have these things. I wanted to talk about just positional headaches in general because when people have positional headaches, there's usually something structural going on. It doesn't have to be a spinal fluid leak. I had a another friend of mine, not a patient, who called me in desperation because she'd seen so many doctors, and she said she's getting these headaches when she bends over. And I was like, "What did the MRV show?" And she's like, "What's an MRV?" So I said, "Well, if you're having positional headaches that are worse when you bend over, you could have a clot in the veins in the brain, this cavernous sinus thrombosis, and that should be done. I mean, didn't you see a neurologist?" She's like, "I saw 3 neurologists." So that was, so she did that. She had a clot in this in her vein in her brain, and then got treatment for that. But it's like these are simple, like these are literally medical board questions that doctors used to be able
Hmm.
to answer reflexively. You don't even have to think about it. It's like, oh, boom, 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 like you're a stereotype, and the answer's right there. And they're missing these simple things. So, yeah,
So, talking about clots, I have a question.
yeah.
Do you see more clotting? Do you see more clotting related symptoms? And do you see more success with clot managing therapies?
Yes, but sometimes it's like accidental. So we have one guy who come in with a diagnosis of long COVID, and he had had a lot of vector-borne testing, but he kind of ignored it because he didn't really think the relationship was too strong. He's a doctor himself, actually, and then he went for an orthopedic surgery, and they happened to put him on Eliquis perioperatively, and he woke up and he felt dramatically better from his long COVID symptoms that he suffered with for a year. And he's just starting antimicrobials now, so the pattern is too soon to tell how he's going to do. It seems like he's responding, but he's literally had just like 10 days of treatment. And so Eliquis for him did result in this, really miraculous improvement. But I don't know, is it the anti-clotting thing? Or, believe it or not, Eliquis has some antimicrobial activity. When I looked into it, it has some powerful antimicrobial stuff. And sometimes things that are anti-clotting, like heparin, for example, it prevents binding sites of like Lyme bacteria from binding to like adhesion molecules and stuff. So sometimes if you prevent bacteria from binding to tissues, it gets rid of the virulence and stuff.
So, how about then vitamin K, nattokinase,
So
such
that
things?
actually came about. I wrote this article in Zero Spin, Untangling Cardiovascular Disease, because my brother Jeff, there's been a lot of tragedy in my family lately. It's not so great in the last few years, but my brother Jeff tragically died of a heart attack at 59.
I'm
And
so sorry to hear that.
thank you. And so yeah, so I was, after that, me and my surviving brother went to a bunch of cardiologists within the first few weeks of his death. And I had a calcium score, which is a CAT scan of the coronary arteries in 2016. It was 0. And then my brother had one that was really high. And he was already on cholesterol medicine. He was already on blood pressure medicine. He went to these cardiologists and like, what else you got? And they don't have anything. Well, you're on cholesterol medicine, you're on a statin, you're on blood pressure medicine. Maybe try to lose a few pounds. Like that's the only tools in the toolkit. And it's pretty sobering that they have nothing else to offer in the context of somebody with a known terrible family history, a known situation where there is a lot of calcification in the coronary arteries. So it got me motivated to look. And I started looking at the traditional eating habits of the Japanese that eat natto. Natto is this like fermented soybean breakfast dish. It's supposed to be like legendarily disgusting. If you don't grow up eating natto, apparently it's like impossible to get the taste for it. But it has 900 micrograms of vitamin K, 2,7, which is a subtype of vitamin K, and 100 milligrams, which is 2,000. I guess they're functional units of nattokinase in one serving, and that has been eaten for 1,000 years. And the people who eat that in Japan are like the super Japanese. So the Japanese people have a long track record of a very good longevity profile with the traditional Japanese diet. And the people who eat natto are superior to that backdrop. So they have 25% lower risk of cardiovascular mortality. a 33% risk reduction in stroke mortality. And interestingly, they don't have an increased risk of hemorrhagic stroke death. And you contrast that to like baby aspirin, which is so commonly recommended by doctors. And even baby aspirin increases the risk of hemorrhagic stroke by 37%. So if you find something that has a safer profile, of course, there are no head-to-head studies with nattokinase and baby aspirin, because what's in it for the pharmaceutical, what's in it for anyone, really, but there should be. But if you look at the epidemiologic studies, nattokinase does look like a safer option. And so I think I mentioned on your program before that when I was at my sickest, for people who don't know, I had a very bad case of Bartonellosis. I almost died. I went to 25 doctors. And I didn't walk for 2 years, and I'd lost 50 pounds and became severely anemic and 102 fever. And anyway, required 24-hour home care and couldn't care for myself. Couldn't lift my arms against gravity or turn over on my own or anything. It was a dire, dire situation. And I did come back from that and I have a full life and everything's fine. So, but what I did not, I don't know if I still mentioned, but one of the things that was still lagging and nagging me was complex migraines. And that started when I got sick. And I had gotten Raynaud's, which is small vessel vasoreactive problems where my feet would turn purple. And then I would have medium vessel vasoreactive problems with migraine and large vessel vasoreactive problems with POTS, which is postural orthostatic tachycardic syndrome. So if these vessels are inflamed by infections and other things that can also inflame vessels, they don't contract and dilate properly, and you get all these kind of weird vasospastic phenomena. And one thing also that I developed was Prinzmetal's angina, which is I would wake up at 5:30 thinking, why am I up? And then a few seconds later, I started to get chest pain and then break out in sweats. And it was always when I wake up from a dream. And at the time that it happened, I would never recommend that anybody do what I did. I was too sick I just thought I was too sick to call 911. I really thought it could be a heart attack, but it's a weird dynamic in your head when you're actually too sick to even want to go to the emergency room. But I didn't. And then the next morning, it happened again. The next morning, it happened again. I'm like, I can't be having a heart attack every day. So when I was looking it up, I was like, holy moly, this is exactly like Prinzmetal's angina. It's usually a benign prognosis. Doesn't usually kill people, although it can rarely do it. And so then I ignored it. And I ignored it for 8 years, really. And then when my brother died, I decided I'm going to take my health, into my hands. And I went to the cardiologist. And I told him I had 8 years of this, almost every morning chest pain. And then he said to me that you have anxiety. I was like, okay, I've had this for 8 years. My brother died 3 weeks ago. I don't think it was caused by anxiety, and I've never really had a problem with anxiety, but thank you. And we got in a little argument, and he said, look, if it responds to amlodipine, I'll apologize or whatever. So he gave me some amlodipine. It got I would say 90% better. And then we made up. And then when I was looking for things to improve vascular health, I started taking vitamin K27 at first at a low dose, and then nattokinase at first at a low dose. And then I went to higher doses of both, and I just noticed that this vasospastic angina had gone away. And it's the only thing that's ever made it go away. And I would have regular complex migraines where I would have neurologic auras, where I would lose vision or I get numb on one arm or numb on my face. I've actually been to the emergency room for it. I mean, it's been very severe. And it's like little TIAs, but nothing shows up on the brain, thank goodness. And but it was a regular thing, so it's gone.
That is amazing.
It is amazing.
It is amazing.
Because they wanted me to take Nurtec and Ajovy and all these different migraine medicine, and I'm such a problem patient because I don't like to treat symptoms very much. I like to get at the cause. It's always been my mantra. I always figured if it was absolutely incapacitating, I would do it. But because I can still function with these crazy migraines, I just lived with them. And but yeah, this has been the biggest single thing to impact the migraines. Then I have to wonder, can we do this on a larger scale? And I'm investigating with my patients. So whereas you say, what's the doses and what are the doses that should be used and what are the doses that are RDA? The recommended daily allowance of vitamins is really like the bare minimum to keep people alive. It's not necessarily what should be done, because right away I was struck by one thing. The vitamin K27 that's in natto, like I said, is 900 micrograms in a single serving. And then in a vitamin K27 vitamin pill, it's 100 micrograms. I'm like, why is it so low? and that's the RDA. And then I look at animal studies, and there's no toxic limit. It's not like vitamin D that's like a U-shaped curve where it's too little, it's bad, and it's too high, it's bad. With higher doses of vitamin K, they haven't established a toxic limit in animals. So vitamin K is necessary for clotting, but more of it doesn't make people clot more. It doesn't cause thrombotic events. So even with low doses, they've done studies showing that, and we're talking about low doses, we're talking like 360 micrograms a day. They show that with women, like postmenopausal women, it improves bone health. But with higher doses, like really massive doses of vitamin K2, and with really super massive, like they've done studies with humans of up to nearly 100 times the RDA, vitamin K1, and even in hemodialysis patients, people who are very, very at risk for abnormal calcifications, they remarkably improve. It's like 75% reduction in calcifications. So
That's so interesting.
yeah.
That is so interesting. So I want to, my apologies for a quick interruption.
Yeah.
For the audience, I saw someone in the comments asking about your YouTube channel. I think Telfer or Tefler. My apologies for the incorrect spelling. So I wanted to quickly show how to find your work. So here, Dr. Stephen Phillips and Dana Parrish, they have written this book, Chronic, The Hidden Cause of the Autoimmune Pandemic and How to Get Healthy Again. Beautiful book. I loved it, and I think I almost look like a salesman for this book, but I'm not. I don't get any cut from Dr. Phillips or from the book sale, or even this link that is in this description of the video is not a affiliate link. So no money is changing hands. This is a great book, and one must know it. And I'll tell you a very simple thing: as we start aging, we'll start developing chronic inflammatory diseases or diseases attributable to chronic inflammation, and knowing about it. I'm actually on drbeen.com. I'm producing a lecture set in which, of course, there are lectures on Dr. Phillips as well, which are about the chronic inflammation. This is, again, I'm not trying to sell my lecture set, but if you go to Dr. Bean and see this chronic inflammation, you will see Dr. Stephen Phillips over here. I think there is one more time. So it is very important to know what is chronic inflammation, how does it happen, and how do we manage it. That's number one. And another important contribution by Dr. Phillips is his Substack called Zero Spin. So please find him there. I want to, before we continue with our interview, if patients want to reach out to you, how do they do that?
And so we have a website, it's stephenphillipsmd.com, which has information with phone numbers and stuff. I've been in Wilton, Connecticut for many years. I opened in 1996. So I feel like I'm just a real Connecticut person. I was born in New York, but Connecticut's been my home for a very long time. So, yeah.
Got it. Thank you very much. So then going back to the natto and vitamin K2 to 7, once again, if we look at the bigger picture, I think that there is a bigger mix of patients who are sick because of the long COVID or acute COVID, or some that are vaccine injured as well. What is your general approach towards such patients?
Well, the general approach is that we concurrently work them up for infections, and there are many. The two most common infections that we see on a regular basis that cause a lot of chronic illness are Lyme and Bartonella. And I've had both. And my experience with Lyme was, I would say, moderate. I was never disabled by it. And Bartonella happened to be the one that almost killed me. And, other people, it's they have a situation where Lyme is worse for them, and they have a relatively mild strain of Bartonella. The name isn't always predictive of how the disease course will be, but there are certain features that are unique to each, but they overlap like 95%. We also evaluate patients for a range of parasites that are common in the United States. When we started writing Chronic, I had no intention of including any information about parasitic infections. And when we started interviewing doctors, we interviewed probably close to 200 doctors for the book. And a lot of the interviews didn't make it to the book because some doctors are just boring. Their data could be good, but their interviews themselves weren't so exciting. But a lot of the doctors said that it's a recurring theme, saying you know what the most neglected field in the United States is? In infectious disease. And I would say, yeah, vector-borne diseases. We're writing a book about it. And they say, no, it's parasites. And it's parasites because the only people that talk about them are integrative doctors and naturopaths, and regular allopathic doctors do not mention parasites. When I thought about it, I was like, you know, he's right. And then I looked at the relationship between parasitic infections and chronic bacterial ones. And in parts of the world where there are lots of parasites, there's a lot of scientific information written on how they interact. And for example, look at toxoplasmosis. That's one of the most, if not the most common parasite in the United States. It's close to 10% of the population will test positive, and doctors routinely ignore it. And yet, a meta-analysis of 9 studies of people who are antibody positive for toxoplasmosis shows that they have over a 300% increase in getting rheumatoid arthritis. And it's tempting to think that toxoplasmosis may cause rheumatoid arthritis. And for all we know, it could. But it could also interact with other chronic bacteria that we carry, suppress the immune response, and make those bacteria more activated, more virulent. So the way that multiple infections interact with each other is not something that's really well studied in medicine, and it should be, because when a mouse is running through the field, it doesn't just get Lyme, it doesn't just get Bartonella or any of them, it gets a mix. And how does that mix interact with each other? They've already done studies showing that, let's say, if you give a mouse babesiosis, their levels of Lyme bacteria in the mouse go up. So Babesia is a cousin to Toxoplasma, distant cousin. They're all kind of related that way. And so it makes perfect sense that toxoplasmosis would do something similar. And we've had cases where toxo has been a driving force for illness. I've seen it. Usually it's not. Usually it's a backseat and just makes things worse. But we've seen patients with retinitis that turned out to be toxo in immunocompetent people, not people who are immunocompromised. We're talking about people with normal immune systems still getting scars on the retina from toxo.
Got it. So if you have we are almost 40 minutes into this discussion. Thank you very much for your generous time. If you have some more time, I would like to ask some questions that Cool Beans are asking in the comments.
Sure.
Okay, so I'm going to start from Nipa. Nipa herself is a dental surgeon, a dentist. Nipa says, Ahuni, her question was, I think, a little before that. Is this thing, Ahuni, is something in India here? In India, we have Ahuni. Is this the same as Netto?
I'm not sure what a Ahuni is.
Me neither.
Yeah.
So Nipa, you just stumped 2 doctors in one ball.
I can Google it as we're talking.
Yes, let's Google that while I go to the next question. What kind of a service we are providing? The fastest service ever. You ask a question and we Google and tell you. Okay, so
yeah, it is a fermented soybean product. The question is, do they put the same bacteria in there? So in general, fermented stuff does produce, longer chain vitamin K2s. And it's not just Natto's not the only source. A nice aged Gouda cheese, they've done multiple studies in the Netherlands looking at heart disease, and they've shown that the highest intakes of vitamin K2 are associated with literally a 50% reduction in cardiovascular mortality. And the chief source in the Netherlands, they don't eat natto there, but they do eat Gouda. And they basically lined up all the different cheeses to find out which has the highest and the lowest. And Gouda really is the top. A nice aged Gouda, 26 weeks, is a very good source of vitamins K2, 7, 8, and K2, 7, K2, 7, K2, 8, and K2, 9. So
got it.
All the long chain ones. Yeah.
Got it. Thank you very much. And for the Cool Beans here, if you have a question, please do write QQQ with it so I can identify them. I saw another question. This is from John. Dr. Phillips, do you do telehealth appointments?
We do. We're licensed in a number of states. It took me a while to get certain licenses. But yeah, we're licensed in many states, but not all of them. And so the office keeps track of where we can do telemedicine. Got
it. Colombian Coffee Bean says, just ordered the book. I planned to do it last time Dr. Phillips was on, but forgot. Well, here is the reminder. Thank you very much for buying.
I hope it helps.
So, absolutely. Let's see. So there is a question: can a virus or their toxin alter our ability to Absorb
absorb nutrition.
nutrition or alter the RNAs to ignore insulin? Meaning, can diabetes or
Yeah. So yes. Yes to both actually. So there are a lot of infections that can inflame the GI tract, and uh, it always amazes me that people they accept that these infections cause inflammation of the joints and the muscles and the nervous system and the brain and the heart and every place, and it just like stops the GI tract. So it's not really so much even, my personal story is included in one chapter in Chronic, but the book is not about me. It's not about Dana. It's just we include the little bit, and then the book is about the greater field. So my story was edited down 10 times because it's too much. It's just too much. Like nobody cares that I had severe GI problems, but I did. I was scoped twice throughout my illness and severe double over abdominal pain. But everyone wants to hear that I almost died and didn't walk, because that's more exciting. So, but I did have GI things, and they only went and got better when I found antibiotics to get my arthritis gone. So when my knees went from soccer ball size to normal size, my GI tract got better, and it really was all the same infection. And it's not as simple. I wish it was as simple as just keeping a microbiome healthy. But the other thing that I think I've talked about this before, but it's another kind of hard sell for people, is that the way that the microbiome is marketed by probiotic companies is that it's friendly bacteria. There's no such thing. Bacteria out for themselves. And if they happen to have a byproduct that's good for us, so be it. But our immune system has to keep the microbiome at arm's length, and that's where it's healthy. So close enough to get the good stuff, but far enough that they don't attack us. Because if the immune system is dysregulated, they are not at arm's length. They get too close, and they behave differently. So in chronic, we refer to them as pathobionts, which is a really proper microbiology term to describe them. Under certain conditions, they behave symbiotically, and under other conditions, they behave pathologically, and they actually will cause us a lot of trouble. So,
makes sense? So once again, just quickly showing the book Chronic over here, going back to the questions. John says, Dr. Phillips, do you have another book coming up? If not, then an updated version of Chronic after all the madness that has happened with COVID.
yeah, it took. Thank you for asking that. Our agent has asked that too. It's just that writing a book was so hard. It really was. It took 3 years, and it's just a labor of love. I mean, I did it to have the information out there so it helps people, and it has accomplished that task. We get calls in the office every day still. It's been out for years already, and we get calls of strangers who are not wanting to make appointments or anything. They just call and say thank you. It's really changed everything. That the doctor read the book, and now the whole relationship has changed. And instead of being like dismissed, they're like, "Oh, now I get it." And that's why we wrote it. And it's so it's doing its purpose. Maybe there will be another one. I'm not sure. It depends if I like semi-retire. But right now I'm working at, in my fast pace, so it's hard to write another one.
Got it. Thank you very much. I know how hard it can be. I'm writing the immunology book, although I've written a lot of it. Uh, Casey says, how does someone with mast cell disorder and reacts to fermented foods get the benefits of foods like natto?
So the first thing about mast cell activation type syndromes is that when mast cells are activated, they're always activated by something. So I probably shouldn't. I don't think I can divulge which university, but think like major university. There's a major university studied Lyme bacteria about 9 months ago, and of all the bacteria yet studied, because I don't think they published this data, Lyme bacteria were the most potent inducers of mast cells out of any bacterial infection in animal studies. But the stereotype for mast cell induction is things like parasites. Parasites really promote a type 2 immune response very effectively. But then just living in California, in California, you must know about valley fever. And valley fever is like the Lyme of fungus. I mean, it's underdiagnosed. It's misunderstood. It causes also mast cell activation. It causes a type 2 immune response. It's intrinsic to how it makes how the illness is perpetuated. So mast cell activation and type 2 immune responses are subsets of one another. And unfortunately, they favor persistence of the organism. There's actually only a very few circumstances. Only when there's large parasites, like multicellular parasites, are type 2 immune responses actually beneficial. Even unicellular parasites, they're not beneficial. So they generally favor the microbes. So I know that that's a bit of a complex answer to your question, but in terms of how to eat fermented foods, sometimes, I mean, I don't personally eat natto. I do eat Gouda, and I like Gouda, but I don't think I could even stomach natto because the thought of it, haven't even tried, because I've heard so many horrible things about it. So I just take vitamin K27 and I take nattokinase. But you say, what's a safe dose of nattokinase? Is there such a thing? What about if people bleed? There have been case reports of people, it's very rare, but there have been case reports of people who take high dose nattokinase and aspirin and who have bled into their brain. And you say, you don't know, is it the aspirin? Is it the nattokinase? Is it the combination? So I'm actually not advocating for the willy-nilly use of nattokinase, but just something to have a conversation with a cardiologist. Because in my own personal situation, I know I've had a million scans because I've had this horrible chronic illness. I've been scanned up and down, don't have any aneurysms. I've had my aorta looked at. I don't have bleeding risks. So I could tolerate a bit of a blood thinner and do okay. It may not be the right choice for everybody. But on a population-based level, we can say from the diet in Japan that low doses of nattokinase appear safe. So 100 milligrams, like I said, on a population-based level, doesn't mean that someone couldn't be out there with a horrible bleeding disorder, but in general, that dose is not associated with a higher risk of hemorrhagic stroke.
Got it. Thank you. John says, is Dr. Phillips licensed to practice in Washington State, West Coast?
I know I'm licensed in California. I don't know that I'm licensed in Washington, but for people who sometimes they have family in California and can do whatever. So I'm not sure. I don't think so. I know I have lots of patients from Washington and Oregon, but we see people in person as well. So people fly in, and if we can't do telemed, or they can go, to a telemed state. And,
Got it.
temporarily.
Got it. Thank you. Thank you. Danger Zone says, can long COVID cause chronic diarrhea?
Well, I would say yes, but the greater question is what's long COVID? I mean, I think it's a heterogeneous group of disorders, and the opinions vary about how long the virus persists, and that's a whole nother discussion. And then my big perspective here is what is the virus done, immunologically, and because these zoonotic infections can cause diarrhea, because we know COVID acutely can cause diarrhea, and there's debate on how long the virus persists. It's hard to say. We're not going and doing colon biopsies on people routinely for COVID, and we should, maybe, who knows. But all I can say is we have seen definitely a subset of patients who, when they've come in after COVID, have persistent GI complaints, as well as it's primarily neurologic and cardiac, like POTS type things. Those are the two most common things. It's basically the triad of cognitive problems, POTS, which is postural orthostatic tachycardic syndrome, and profound fatigue, like a chronic fatigue type picture. And that's what we usually see in patients. Yeah.
Got it. Thank you. Kim in Nature says, can Dr. Phillips write an RX for IVM for me? I have had it for 2017, but the refills is not getting them anymore.
I can't write prescriptions for people who are not actually my patients. It's against the law. So I'm sorry about that.
Got it. John says, so I think we're going to triangulate you and find you where you are going to be.
I can do telehealth in Florida, yes.
Okay, so telehealth in Florida, yes. Okay, so very good. Thank you. Andrew says, are chronic inflammatory diseases associated with some epigenetic changes? How relevant is it, and is it reversible?
So yes, I mean, epigenetic changes are reversible by definition. And, think of them as barnacles that attack the DNA as little tags, and they can be snipped off, and it turns genes on and off, and it's not changes intrinsic to the DNA itself. So all the things that we encounter in life, whether they're inflammatory stresses from infections or they're toxic stresses from pesticides, it's amazing to me, truly amazing and sobering, the corruption that's going on in this country. I had read that they recently allowed, it was like 2 years ago, a pesticide for the citrus agriculture space that's been banned all around the world. And they just allowed it in the United States like 2 years ago. And I remember I tweeted about that because I just don't understand. It's considered such a toxic pesticide. And then, my dad, may he rest in peace, he ended up getting a Parkinson's type syndrome toward the end of his life. and he was exposed to a chemical as part of his job. He was a nuclear physicist, and he worked in some secret stuff for the government and all this other stuff. He was exposed to a chemical on a regular basis that's known to cause Parkinson's, like well known. And there's a lot of toxic. We've like created this toxic world that we're living in. Do you guys ever talk about in your show how the sperm count has been going down and down and down
Yes.
and down? In like
I
30
haven't talked,
years, we
but
will
I've read.
not. What's that?
I haven't talked, but I have read. Yes.
We will not be able to have natural conception within 30 years at this rate. And I don't, it should be like, shouldn't that be front page news? Like, shouldn't it be like
Mhm.
shouting from the rooftops that, oh, yeah, no one's going to be able to conceive, everything will be in vitro? Because they'll make it the new normal. They'll be like, I'm going for my in vitro fertilization today. And that's how everyone's
Mhm.
going to have babies because of what we're doing to our environment. It's crazy. That's what
That's
happened.
very
Yeah.
interesting. I was reading a study today. That study said that how microplastics in our food and in our body's environment
Mhm.
actually augment SARS-CoV-2 to bind better with ACE2.
Oh, really?
So I
Oh.
don't know what else these things do, but yeah, you're correct.
You hear about you hear about estrogen-like effects all the time of the microplastics.
Casey says again, triangulating to find you. Telehealth in Virginia.
I'm not sure. If not Virginia, I'm sure there's probably states around there, but I'm not sure. Virginia's
Got it.
not that far, so
Got it.
no.
Nipa says, I think you just discussed it a few minutes ago. Nipa says, how much can you eat netto? How much the dose for netto?
I mean, the dose, how many grams is it? I've never actually eaten it. I think it's, I don't know. I'm not really sure. It comes in like a fairly standard serving size, whether it's 100 grams. I'm not sure. But
Okay, so Nipa, you'll have to Google it or you'll
yeah.
have to watch my video about it. Meeple Art says, if fungus was resident, would it most likely be sitting in sinuses or could it infiltrate to other parts of the body like brain or lungs? And what would be suggested to eradicate?
So fungus was resident. So you're saying if somebody had a chronic fungal infection, I mean, fungi are like snowflakes, like everything, so many different kinds. So there are these invasive fungi that can infect, patients who are not immune compromised. Valley fever is a perfect example. So they like dimorphic fungi, histoplasmosis, blastomycosis, um, and then there's the more routine ones like aspergillus. We see invasive aspergillus in patients. Sometimes, immunosuppression is such a relative term. People who have COPD can be at risk of getting aspergillus. And are they immune suppressed? They're not on immune suppressive drugs, but their membranes are compromised. So, um, so the question is, would it be most likely to be sitting in the sinuses? So it can infiltrate to other parts of the body for sure. So the invasive fungi, like valley fever, for example, because it, Dupixent, that drug that blocks the Th2 response. It's a drug that, they use it for eczema, atopic eczema. And they had this, I don't know if I spoke about it last time I was on your show, but they had this case of a little child who was dying of valley fever, and they could not get it under control with the most powerful antifungals, and it was everywhere, all throughout his body. And they added Dupixent, and they saved his life. And all it did was shut off the type 2 immune response because that response favors the infection. It's immune suppressive. And they don't really look at Dupixent as something to assist in like getting over chronic infections, but like LDN, I mean, it's an immune modulator at the end of the day to fix a broken immune system. I think it has a lot of, I think that drug should be studied.
Got it. Thank you. So one last question. It's almost an hour, and I know you're on the East Coast.
Yeah.
Uh, Danger Zone says, after starting nattokinase, my legs are less sore. Could that be a spike protein thing or something else?
I mean, there is some evidence, I'm sure Danger Zone, that that it can, at least in test tube studies, dissolve spike protein, but also nattokinase has anti-inflammatory aspects as well. And for me, it lowered my cholesterol markedly. It lowered it as much as a statin, which is not supposed to, but it did. And I was shocked because I did not expect that. It also lowers blood pressure. So it has a multimodal effect on cardiovascular health, but the anti-inflammatory effect could be reducing pain. And I don't know anything about the baseline history here, so I'm not sure, I guess, if there is long COVID going on with danger zones history, but, it is something that people, how is Dana doing? She's doing great. It is something that people do take, and it's one of these supplements that is, a lot of people do like it. Dana's doing quite well. I just saw her this past weekend, actually.
Good to know.
Yeah.
Excellent. So thank you so much for the insights for the current medical era. It's so interesting. I think that medicine as we knew it is not going to be that medicine anymore. And doctors will have to change, and the medical community will have to change, and the therapies and interventions. And there is a lot of change that has to happen. Will it happen? I do not know yet. And thank you for sharing that. Thank you for sharing the various therapies, especially nattokinase and K2. So before we close, any comments, any suggestions for the listeners?
There's one last thing that happened recently. It's more of the line of like the rush doctors doing things that are like notoriously not great these days. I had a patient recently who came down with a COVID-like syndrome. And I know COVID is all over the place, and we tend to think that every infection is COVID. She didn't have any upper respiratory infections, though, and she's from Rhode Island. And her doctor called her in Paxlovid with steroids without knowing any data about anything. And she wasn't desaturated. And he didn't ask anything about tick exposure. It turns out she had ticks in her bed. Shortly before this happened, she found ticks in her bed. So here it was, he called in Paxlovid and steroids. And the long story short is she wasn't desaturated. Her rapid antigen test was negative times several. She had no upper respiratory infection. So it was just a comedy of errors. Like, there's really not a good role for steroids, and people who are not desaturated could make things worse. And plus, she ended up having a vector-borne infection that could have been really detrimental to give steroids during that. She responded to doxycycline and turned around in 24 hours. And we think it was ehrlichiosis that she had. And, if she took steroids, it could have, ultimately had a really bad outcome. And that's just something I saw also recently. And it's just a screw up, And there's so many, I'm seeing more medical errors now than I've ever seen. I've been in practice in such a long time already. I've never seen anything like this. And I think it's just, I think it's the volume. People can't hold up with the volume, and they're doing stupid stuff. So just, we can look.
Got it. So with this, thank you very much for your time, for the insights. And I am going to close on your book once again. So audience, if you don't have this book is worth having. And I'll tell you how. Other than medical books, I don't read books twice. I read some book and usually not even finish it. This is the book I've read twice. And this is Dr. Phillips's Substack, Zero Spin. Find that out and use that as well. Dr. Phillips, with this, thank you very much. And Cool Beans, thank you very much. I'll see you tomorrow.
Thank you, everybody. Okay, good night.